Good morning, everybody, and welcome to this morning's monthly South East Perinatal Mental Health webinar. Thank you all for joining us. As usual, I'm just going to quickly run through housekeeping. So please can I encourage everybody to keep their lines on mute and turn their videos off until they're asking questions. Obviously, we'll just keep the videos on for the speakers. If you want to raise your hand, please do to ask a question. Obviously, please put comments and questions in the chat box as well, and Jenny and I will keep an eye on that. And then just to remind everybody that we are recording the webinar in order to put it on the website for those of us people that aren't able to join today. So just to let you know that the recording has started. Okay, so I will hand over to Jenny.
Good morning, everybody. So today we have a focus on substance misuse in the perinatal period. We're going to start with our usual national update and some useful resources and publications for you all. And then our first speaker is our very own Yvette Garden, who's going to talk about the South East Perinatal Mental Health Academy, because that is actually launching. So Yvette's going to give us a demo. And although this is obviously directed at our colleagues across South East, there may be something of interest there for other areas if you wanted to replicate a similar thing yourselves. And then into our substance misuse speakers. So we're delighted to have, firstly, Dr. Neil Ayton, who's going to be talking about his multidisciplinary clinics, but also much more broadly about substance misuse in the perinatal period. And then we're going on to Dr. Andrew Cairns, who was one of the co-authors of the Mental Health and Adversity chapter in the Embrace report. So as usual, a very full and packed agenda, and I'm going to hand back to Liz now for the national update. So I'll pop up again in a minute.
Thank you, Jenny. Lovely. So whilst I'm giving the national update, please, we do encourage people to just pop in the chat who you are and what organisation you're representing, so that you can get a feel of who is on the webinar today. So just a couple of headlines. So some of you will hopefully already have been registered for this, but the 4th Maternal Mental Health Services Implementation event is happening online on the 28th of April. There are details on this slide in terms of how to register. Obviously, we would encourage as many people as possible that are involved in maternal mental health services and interface with the maternal mental health services to attend that event, and it's being obviously hosted by the national team. So further details are available on the collaboration platform. Then also following on with maternal mental health services, there was a webinar held last Thursday, which some of you may well have attended on the 24th of March. But if you haven't, I just wanted to highlight it. So the link to the webinar recording, which is available on the collaboration platform, is available on the bottom of the slide. And really, the webinar was about flowing the data to the MHSDS. So giving clarification, etc. So we would encourage that anybody in terms of service leads and the trust IT teams who will be submitting the data to watch that in order to give further information. And I'm just going to highlight a couple of key elements from that webinar now. So the reason why it's so important for us to submit the data is obviously it contributes to the access target. So it's really important that this will contribute to the additional, the 66,000 women with moderate and severe and complex mental health difficulties, which will access specialist care by 2023-24. So the maternal mental health services access figures will be combined with the specialist community perinatal mental health team service figures and contribute overall. So there's a real opportunity during this next year in order to take us to that next level of the additional women that will be seen. And then women in contact with MMHS will count towards obviously the access ambition and also the metric definition, which I will go on to next. So in terms of the definition, it is women who have been in contact with specialist community perinatal mental health services and or maternal mental health services who have received at least one face-to-face or video appointment during the financial year. It remains the same as we've talked about many times before at previous webinars, that telephone, SMS or email contacts do not count towards the national access metric. So it is face-to-face or virtual video appointments. And women are only counted once in a financial year, even if they receive multiple episodes of care. So that's just to be clear on the definition. And then obviously it's not just about recording routine about the access, it's about recording the routine outcome measures as well. And really important element of our patient-centred care in doing this. So there are various guidance documents that are available, and we've included the links there that you can follow for further details in terms of outcome measures. Okay. Also, the national team have provided us with description of other data and guidance, all relevant, all really useful information that's available on the collaboration platform, and the individual links are included here. And then also there is the MMHs Dashboard, which is due to go live in the next couple of weeks. And as soon as that does go live, there'll obviously be national announcements about that, and we will also be announcing it regionally. But it will enable all the MHSDS data in one place at provider, CCG and ICS regional and national level. So it will support transparent conversations with the systems, and particularly for commissioners and providers together. It will provide an easy view of referral rates from sources such as maternity, general practice, health visiting, primary and secondary mental health. So we'll be able to see where we're getting our referrals from, and also gives us the opportunity then to target areas and educate them about our services if we see that there are pockets where we're not getting referrals from. And then also enables us to look at data quality issues, so where we may need to identify and work with data quality issues, which is a really useful tool. So as I say, that will be launched in the next couple of weeks, and no doubt we'll give further information at the webinar in April. Okay, so in terms of announcement, I wanted to just highlight from Jacqueline Dunkley-Bent, our Chief Midwifery Officer for England, the announcement that we've had in terms of the additional money to boost for maternity for patients and their families. The link there at the bottom of the slide will give you further information, but this is an additional £50 million for trusts across the country, £34 million that will go into the local maternity and neonatal systems, and 45 million of capital funding. So a massive chunk of money to be invested to further enhance and develop our maternity services and pathways. So really important, and there will be further information coming out about this as we go further into the next financial year, which we will share with you. So I'm going to hand over to Jenny at this point, who's going to go through some of the key resources that we've had in the last month.
Hi, as usual, it's a little bit of a sort of potpourri. There's lots of different resources to get through, and I won't labour the point of any of these, but they're all there on the slides when they come out for you to have a look at. On the left there, it's really worth raising awareness of these short films that the Acacia Trust have been part of. So these have a number of different aspects of perinatal mental health issues in different languages, and the languages are listed there. So hopefully they'll be helpful to all of us in our practice. And on the right there is just a little film that Tommies have done about being a mum, which is a short film, but it covers a lot of those more diverse aspects, like what if your baby dies, and those sorts of aspects of being a mum that sometimes get forgotten. So that's worth a watch, I would say. Next slide, please. Okay. On the left, we have a resource in relation to birth trauma for all women and birthing people, but obviously useful for all of us to read. So the link to that is there. And do you know what? I've confused myself here. I can't remember if that one on the right is a different resource or whether it's a picture of the same resource. So I'll leave
the
you.
Same resource.
Oh, thank you very much, Yvette. Thank you. So that's one resource on there, understanding post-traumatic stress disorder after birth. So particularly thinking about our MMHS colleagues there. Next slide, please. Okay, we've got the results of a study into the experiences of perinatal mental health care among minority ethnic women during COVID. So that's a good read, thinking of our health inequalities agenda. And then on the right is a really good article by Evie Kavanagh, who really makes the point about medication in pregnancy, but it's actually a really well-written article from the mum's point of view. So I'd recommend that. Okay, next slide, please. Just giving you an early heads up for a couple of awareness dates coming up during May, if you want to do anything to celebrate these. On the right, we've got Mental Health Awareness Week, but obviously the biggie for us is Maternal Mental Health Awareness Week, which is early May. So there's those dates there for you and links if you want to do anything to celebrate those. Next slide, please. This article, I think, is really timely at the moment because with the imminent publication of the final Ockham report, I think midwives are going through, you know, a really difficult time at the moment, lots of bad press, and we know what an amazing job you all do. This article, I think all of us should have a look at this. It's not saying anything that you wouldn't have thought of, but it's just saying that a lot of the pregnancy problems are all of our problems, and it's not just about that giving birth bit. It's very much about the bit before and the bit after, and talks about things like the importance of contraception and all health professionals having conversations about contraception so that babies are planned, because we know outcomes for unplanned babies can be a lot more difficult. So I would recommend that because I think it's just a humbling reminder that we're all in this together, and you know, what's happening to our midwives is really happening to all of us. So that's that one. Okay, next slide, please. Oh, exciting. So now I'm going to hand you over to Yvette, who's going to talk to you about the Perinatal Mental Health Academy for South East. So thank you, Yvette.
Lovely. Thanks very much, Jenny. And as Jenny says, I'm Yvette. I work within the South East Perinatal Mental Health regional team with Liz and Jenny. And some of you may be familiar with our new Perinatal Mental Health Academy for the South East region, but it is now ready for people to access and use. So we wanted to highlight it today. So if I could have the next slide, please. So our inspiration actually came from the Wessex Maternity Academy, and thank you very much, Holly Green, for all her guidance and advice at the beginning. And what we wanted to create was a one-stop shop for all our South East colleagues, whether it's perinatal mental health or even maternity, to access our training, which we quite regularly bid for funding through Health Education England and other pots of money. But we wanted somewhere where not only can you see what training is currently on offer, but also resources and useful links. So I'll just give a quick breakdown of the different areas of the website, and then I will go into the website to show you it live, so to speak. So our landing page obviously has our introduction. It has a map, and this is our NHS England and Improvement region. So it will show you whether you work within that region, whether you can actually register your interest for the training. And then we have along the right hand side, as you look onto the screen, the resources. If you could move on to the next slide, please. And then we have our calendar of live events here, and I will show you in more detail in a moment. So you can click on training that you're interested in, see the details, and then follow the link to how you can register for those events. And then we also have an online form for making any suggestions, but it could be for the website itself, it could be for future training and events, or other resources that you'd like to see on the website. So it really is, please do use it to show us and tell us what you would like to see on this website. It is going to be regularly reviewed, and so any feedback would be much appreciated. And next slide, please. And then we have, as I mentioned before, useful links. So you can just click on them links and it'll open up the page in your browser. Coming soon, so this could be for training events that are coming up, but we're not quite ready for people to register yet, but so you get an idea of what may be coming up, so you may not have to fund that for yourselves, it could be funded for you. And then along the bottom of the page is the latest news. So what I shall do now, I shall share my screen, if that's okay. Bear with me one moment. So here is our top of the page with our lovely banner. It took us a long time to find those images, so we hope you all approve. And as I said, here's the map of the NHS England and Improvement region. So that's our region. And that key is for our ICSs, so Integrated Care Systems and Integrated Care Boards. So here we have a more populated calendar now. And I just wanted to highlight the Gypsy and Traveller Me Learning training that we have on offer. This is actually an online, I think there's 4 module learning, and we have quite a number of places available for colleagues across the South East. So we really wanted to highlight it today just to encourage people to go on and self-register. You can do it in your own time. I don't think there's a time limit on it, and you do get a certificate at the end, but we thought it was a really great training for everybody to undertake, and we want people to take advantage of it as it's on offer. I think we've got our license for at least 10 months to a year, so it's there for people to access. If I just go on to this perinatal mental health, if you click on the actual date, it gives you a little bit more information, and then it gives you the event bright link of how you can register your interest. And I just wanted to highlight this because you are just registering your interest, and we will let you know whether you have been successful in securing a place on the course. So it's a little bit confusing because sometimes our trainers will then send out another link, but I just wanted to highlight that you do need to click on to register your interest. So we're hoping that all our training events will be accessible this way moving into the future. And then if I just click on there, and if I just move further down, you'll see here's our suggestion box. So it's very quick and easy to use, and that will come through to us. And we can't guarantee that the training or events or the suggestion you make will be made, but it will help us even create a wish list for training to bid for in the future. And then we have our useful links. again, just click on the link, and then the coming soon is, so you can see we've got 5 to Thrive, which we'll touch on later, working virtually training, so you can get a flavour of what we're going to be offering in the future. And then we have the latest news, which it will have the links to our recordings and all sorts of different latest news that you may be of interest to you. So if we go back to the slides, stop sharing. Hopefully Liz will bring up the slides again. So that was a whistle-stop tour of our academy. If we go to the next slide, Liz, please. So again, I just wanted to highlight our Gypsy and Traveller cultural awareness travelling via Me Learning. When you go onto the academy and click on the link, it brings you the self-registration form up, and then you have your own account with them, so you don't have to go back onto the academy. You're all set up with them. But like I say, you know, we're hoping as many people as possible will access that training over the next at least 6 months to make sure you all have the opportunity to complete it. And next slide, please. And then this just gives you the ones that were on the academy but that are coming up in the next months coming. The cultural competency and safety workshop. There are 4 workshops, but they are the same, so it's just spreading it out across the year. So hopefully with the pressures, people will be able to access that in the future, but it is the same course. And next slide, please. And I didn't know if Jenny or Liz wanted to talk about the 5 to Thrive that's coming up.
I jump in here.
Oh, well done, Liz. I'll let you.
Thank you, Jenny, and thank you very much, Yvette. And it's a great resource, so please do use it. And we look forward to receiving your registration of interest for the various training courses. So 5 to Thrive is one of the training courses that we will be doing, which is going to be kind of from a system approach in terms of the principles of the 5 to Thrive model. And we're going to do kind of at different layers. So there will be an introductory webinar, which will be for the ICS system leads, and that's taking place on the 27th of April, and further details and invites are due to go out imminently. There will then be a kind of a workshop webinar that will be to kind of all stakeholders. There's like a capacity, I think, of 500 people for that webinar. So really, again, to kind of introduce the concept and the principles of 5 to Thrive, and then there'll be further training in terms of both practitioners and then a kind of champion. We'll have champions within the Southeast as well, so that we can do a trainer approach going forward. So we really just wanted to highlight it as a as training that we will be doing going forward, and there'll be further information that will be shared at both these webinars, but individual webinars for 5 to Thrive. Okay, so I think I'm going to hand back to Jenny at this point, and she's going to introduce Neil.
Okay, I am really excited to introduce Dr. Neil Ayton, who is going to talk to us about substance misuse in the perinatal period. So over to you, Neil, and thank you very much for agreeing to do this for us.
Okay, hello. First of all, thank you very much for inviting me. It's a privilege, obviously, to be part of this meeting, and I'm just so grateful to see the attention that's been given to this important subject, really, both perinatal health and substance misuse. It's been amazing to witness the growth and attention to perinatal mental health over the past 5 to 10 years, certainly since my role in professional practice, and that's been fantastic to see, and long may it progress further. I've only got a short time today, so I thought I would share with you a few reflections on these areas. If you go to the next slide, please. Firstly, just working with substance misuse in the perinatal. Sorry, I'm just sorting my headset out. Over the last 20 years in the perinatal period. Also, what grew out of that really, which was a clinic for prescribed medication in pregnancy and breastfeeding, which is very much a different thing. And then perhaps some thoughts to inspire you to have a think about where we might need to go from here. Next slide, please. So I work in the One Stop Clinic, which we started just over 20 years ago now, and it's a multi-agency, multidisciplinary clinic for pregnant mothers and their babies when there's associated substance misuse. It's a relatively, I think, unique model, but hopefully is beginning to sort of, this approach is beginning to gain ground and credence elsewhere. The points really, I haven't got time to discuss in detail about everything, but it's open access, and referral can come from multiplicity of sources, including mothers who come again because they fall pregnant once more. We try and be flexible in terms of giving the care according to the needs of the clients. So some mothers might just come for one appointment, advice, and perhaps a neonatal plan, and we might not see them again in pregnancy, whereas other mothers might receive the whole of their midwifery care from our sort of dedicated team of a couple of substance misuse, really experienced substance misuse midwives who've been working in the clinic. We used to have an obstetrician associated with the clinic, but since that antenatal clinic has moved in our trust, that's become more problematic. There's myself involved from a neonatology perspective, and we also have a neonatal nurse practitioner involved. Obviously, the substance misuse service is involved as well. In Brighton, that was recommissioned last year during COVID, which also created some additional issues. Social services has, over the last decade or more, been involved as well in coming to the meetings, but they, over COVID, have gone online, so that again puts this type of working and style of approach under threat. We've also had really useful and important input from the Specialist Perinatal Mental Health Service over time, both in terms of trainees who've been able to attend and also positively contribute to the discussions about patients, but also specialist nurse involvement, which has been so useful too. However, obviously that's limited by capacity really. And I think that the role of the Specialist Perinatal Mental Health Service in this type of clinic springs out really that actually the situation doesn't remain the same throughout pregnancy. You know, situations and mental health and all sorts of other things fluctuate as time goes on. So, you know, so sometimes assessment for treatment or referral doesn't stay the same and needs to be reviewed and reassessed. It's also really helpful to have appropriate professional advice, even if people aren't meeting thresholds for treatment in what are often complex scenarios. And finally, access to mental health databases in terms of understanding whether mothers have been previously referred for treatment or monitoring or been seen in the community or are under the care of other psychiatrists, which we don't have within our hospital trust access to that type of information. So sometimes, for example, we've had situations where because of previous knowledge or previous referral about what has happened in the past, that has meant that they've met threshold for referral and involvement of the Perinatal Mental Health Service when we wouldn't have known that had this not been the case. And then finally, I would sort of not underemphasize the importance in this type of work with flagging up people who are around, and so that when things appear, they know about what's happening within different services and within regular meetings within our own individual services. So I think it's challenging to work in a multi-agency, multidisciplinary clinic. We use different information systems. We have different ways of working. We use different language. All of those things make life more challenging. We also have unique perspectives. And the more I've gone on over the last 20 years, I have remained convinced that the multidisciplinary and multi-agency input is so vital, because it provides a perspective that you can't have just by yourself. So next slide, please. What's important? Well, I would emphasize teamwork for the reasons that I've just explained. We try and emphasize that any engagement is better than no engagement. We used to run a non-appointment. We didn't run appointments. I was talking maybe 10 years ago or more, because sometimes non-attendance at appointments was taken as a negative thing, and that was thrown back at clients, which wasn't helpful. Whereas we were actually wanting to encourage engagement, not actually take non-attendance as a negative thing. So that those sort of issues are important. We try and provide evidence-based information, but also on top of that, where there isn't evidence, a huge amount of experience accumulated over time. We do emphasize stability, and that's interesting because there's such an emphasis, particularly if you go to residential substance misuse placements and within social care and health, on abstinence type modelling. And then finally, we do try and pay really close attention to mental health and dealing with mental health and coping strategies and addressing possible areas of support. And that's because actually, if the substance misuse behavior is part of long developed, long practiced coping type strategies, then obviously if you haven't dealt adequately with mental health, then that sort of thing just continues. So sometimes dealing with that, or dealing with, well, what's the most important thing for you, it is so crucial to helping it move forward, when actually in many situations mothers are going to clinics or seeing professionals or going elsewhere, and everyone's concentrating on the substance misuse, not actually the problems that are creating, involving and contributing to the use of those types of things. And that, of course, gives the mothers better agency and control over what's happening. And I think that's crucial to that whole situation. Next slide, please. So I'd highlight what's different in pregnancy, and I don't just mean it's just about the baby. And just pick out a few themes, really. I think motivation is crucial, because nearly all women experience the strongest motivation, I think, or my perception is, that they will ever have, more than any other time. It's not just about them. And I would say nearly all mothers, with almost no exceptions, want the best for their baby, even if that's not seen or ascribed to them as a motivation. So that is important to work with. Secondly, I think the standard approach to substance misuse doesn't apply. And many people have got experience of substance misuse workers, or in other areas outside pregnancy. And I think there are a lot of inherent dangers in applying those same types of approach within pregnancy, because it's different. And I haven't really got time to elaborate that hugely now, but just to throw in a few ideas, it's different metabolism for the mother, changes in pregnancy, so the effects and lengths of how drugs act is different. Responses of the baby are different, and about how that should affect the mother's behavior and what she might do, or the changes she might want to make. But there's a lot of else for mothers to think about in pregnancy too. And of course, everyone's focusing on the substance misuse, but of course she's thinking, I've got all these other kind of things to think about, and how are we approaching those sort of things? And, you know, sometimes it's important just to put the hold on the situation, and this is where stability can be important. You're not going to deal with 10 years or more of substance misuse in the next 3 months of pregnancy. So sometimes you just have to put those things on hold and concentrate on the things that are important, that can't be replicated at any other point. And that's where I would prioritize the attachment issue. You know, Maslow had a lot of useful information to contribute here. You know, if people are sofa surfing, you know, you're really not going to get them to come to parenting classes very easily. You know, there are different priorities for parents. Finally, thirdly, the clock is ticking. And of course, that has an effect where the approach to referrals for treatment, assessment, and management are different time periods outside pregnancy. For example, you know, alcohol services locally, it's just a different framework. And of course, we're trying to refer, and then it takes them, you know, you put it in, and then it takes another 4 weeks for an assessment meeting, and then another 4 weeks before someone, you know, and these things, you're thinking the clock is ticking, this baby is being harmed by continued exposure. We really need to get a move on here. And no one's kind of thinking about those aspects, those perinatal aspects, in terms of the clock ticking. And then safeguarding. I think that is there hovering in the background, and it affects mothers in terms of how they deal with highly stressful situations and coping strategies. So that can approaches an assessment about safeguarding can send things spinning off. So I think, you know, that's where services can work together as to how and when those things are approached and handled to make that better. And I would say also safeguarding means that many women are not only they're presenting late to services, so that gives you less time, so it all has to happen more quickly, but also I think mothers become much more ambivalent about the attachment to their child inside, and I'm talking antenatal attachment here, for which I haven't got time to elucidate on further, but I think there's precious little importance attached to how that might be developed or used to help improve engagement and motivation, and also engagement with services. Next slide, please. So I just kind of raise what's the most important thing to do first is often the question that we're asking when there's so many complex things. And I had a conversation with a Sunday Times journalist a few years ago about this kind of issue, and, you know, a drink, a fag or a spliff, what's your recommendation? And I'd encourage you to think about that, because in this type of situation, actually, what's the most damaging for this baby in the longer run? And for me, it's not the heroin, it's often the alcohol, for example. And, you know, women get referred to smoking cessation, but actually they're still using all sorts of other stuff. And actually, I'm kind of saying, well, actually, if smoking helps you in that way, then maybe that's a better thing to do. So, you know, these things are relative. And of course, my comment got completely misinterpreted and picked up by the Daily Mail and placed next to that picture of a cannabis plantation, as though I was dishing out this information in an antenatal clinic. Yeah, sure. Yeah, have a spliff. So you can kind of see why these things can be misinterpreted. Next slide, please. So what else do we do differently? We manage withdrawal differently in this clinic, and we have a long experience of doing this. And I'm anxious to try and publish some of that data. And we prioritize keeping the mothers and babies together. And throughout this process, we prioritize attachment. And I've also done a presentation actually at the Tavistock Clinic in London, which is obviously, as many of you will know, is the centre and the origin of the theories about attachment from Bowlby. So how do we do that? Firstly, we try and keep mothers and babies together on the postnatal ward, even if treatment is required. So that's a struggle, and we don't, I have to say, all hands up, we don't manage that within our own trust all of the time. And of course, midwifery staffing and all of those issues which have already been alluded to today impinge on that situation. But I think sometimes we're not honest about the reasons for sending the baby upstairs. I absolutely get it when the midwife is saying there's 2 of us on the postnatal ward, I've got this and this happening, and actually if the baby could go, this more baby that's more difficult to look after can go to the neonatal unit. That's just one extra thing that I'm feeling that I can't manage. I really get that. And in those sort of situations, I think we just need to be honest about why we're making that referral. It's not about the withdrawal. It's actually about staffing, and it's about management of activity and those sorts of things. But just a little, I suppose, vignette there about that. So we try to rapidly stabilize babies with treatment for babies that need withdrawal in the first few days. Really, we don't wait and until they meet certain thresholds and things. If they need treatment and their sleep or their feeding, for example, is disordered, then I treat. I think we sometimes need to manage different phases of withdrawal from different medications. Again, I haven't got time to go into that today, but withdrawal from alcohol, if mothers are using alcohol heavily right up to the end of pregnancy, would happen in the first 24, 48 hours. You might see a withdrawal from from methadone happening over day 2 to day 7, that sort of period. And then you might see withdrawal from benzodiazepines, such as diazepam, happening over 2 to 5 weeks, which might be in the community. So, and those need managing in different ways and are, I think, poorly managed. So we also go for early discharge for that reason, because we're trying to keep mother and baby together. And of course, if the safeguarding is involved here and it's foster placement or whatever, then it's early discharge to consistency of a foster care replacement. And then I don't change anything for the next few weeks. I don't put these babies through repetitive cycles of withdrawal and then just as they feel comfortable again, we reduce the dose. I don't change anything. And then I negotiate when we start doing the reduction in the community at a later stage. Because I think if we're firing off in an abnormal hospital environment, and then these babies' nervous systems are activated every time we reduce their drugs, and we're trying to get them out quickly. So, and they often have prolonged stays, and there's lots of data on that, both in the UK, but particularly in the States. Then these things are harmful, and no, absolutely why we end up with babies that are really jumpy and difficult to control. My contention is that when withdrawal is managed appropriately and well, that these babies should be behaving normally, like normal babies. And indeed, many of the foster carers would, I think, support that. Next slide, please. So that was just really a romp through kind of what we do and why we do it, and a few of the kind of issues that raise. I'm going to just move on now to medication in pregnancy and breastfeeding. And this is a separate clinic that arose from the work I do in substance misuse work, because I was like, can you see, because this mother's on medication and the baby might withdraw, oh, you're the guy who deals with that. So they kind of ended up coming my way. And then gradually, I think over perhaps 7, 8 years ago, the nature of the clinic began to change, and we started to see mothers who were much more complex. And I'll show you some examples of that in a short while. And many of those mothers with chronic ill health or chronic health conditions often have overlapping issues with mental health. And I think that's so enshrined within this type of clinic that it's crying out. It isn't multidisciplinary at the moment, but it's crying out to be so. And that's something which I would love to develop. But I think historically it's poorly dealt with. And of course, mothers are kind of walking this tightrope. Next slide, please. They're trying to walk this tightrope about all the stuff that they believe, about all the stuff that people are telling them, and you mustn't do this, it's dangerous, and actually I want, just what's best for my baby. And then they're getting all this different conflicting advice from different professionals. And I think that graphic kind of, for me, describes in some ways the experience of what mothers express in that type of situation when they are on all sorts of stuff and then become pregnant for one reason or another. Next slide, please. So whose problem is it? And I think that's an issue. Obviously, obstetricians have good background in terms of pharmacology training in the past, but are not so interested, perhaps understandably, in what happens after birth in terms of the breastfeeding. Neonatologists traditionally are dealing with the baby after birth, so we don't tend to see what happens. And I suppose that perhaps I'm a little bit unusual in that I kind of have one foot in the antenatal period, perhaps a little bit more than most. I think many midwives see their mothers in having difficult situations and not knowing what to do and being steered in different directions and confused by all of this and want to really help. But I think struggle with the support, training, and the way to help them in the best way. And of course, then overlapping in all of this is some of the perinatal mental health issues as well, and the lack of commissioning perhaps in that particular area and until you reach threshold treatment. So I think there's lack of good quality information, both short-term and long-term outcomes. There's poor levels of systematic studies. Drug legislation doesn't help because almost no drug you can give to a pregnant woman or somebody under 12. So that's a real issue. And of course, conflicting advice. Next slide, please. And then into that kind of mix, you've got like committees who make recommendations who in general, and I've just sat on a NICE committee for the last year, we've just published some NICE quality standards for fetal alcohol syndrome spectrum disorder and to do with drinking and pregnancy. And it's interesting how committees behave and how that's different to perhaps what you might say as an individual and the positions that you get put in. Professionals will be often thinking in this type of situation, well, what do I need to say and what do I believe, and actually what do I need to recommend to be safe, and do I need to cover myself, and all of those kind of things. And then pharmacy companies, issue their edicts, don't give to pregnant women. So you're stuck really. Next slide, please. And, how do you assess risk, I suppose, is really important, because as professionals, how we assess risk and how you as an individual and as a person within a professional context assess risk is going to be different to how perhaps others do, other professionals in your similar situation, but also very different perhaps to how the client, the pregnant mum, might assess risk. What's the risks to her? And then where does uncertainty fit into that? And I love that quote, risk is measurable uncertainty and uncertainty is unmeasurable risk, because I think it really kind of summarizes the situation. Next slide, please. And then I love this little quote I found in a mug in one of our junior doctors in the coffee room. Going to Google and trying to find stuff out and in non-systematic ways and without access, and then it all just gets a little bit confusing. Next slide, please. And then finally, for clients, for mothers, pregnant mothers, there's the stuff that they imagine that is really important or is going to affect them, or that people have told them that's really important. And then there's what's real. So it's how can you provide information that can help correct perhaps misconceptions. And sometimes I find frequent misconceptions about both risk and risk of damage to a baby, for example, in that type of situation. Next slide, please. And in all of these discussions, we forget to balance all of the negative side with the positive side. We forget about feeding into the positive aspects of breastfeeding, bonding, attachment, the effects of maternal depression. In other words, I suppose what I mean by that, actually, I haven't worded that well. Perhaps I mean the effect of untreated maternal depression and the good evidence that exists to show. And many of my colleagues, perinatal psychiatry colleagues, are really good at kind of explaining and understanding that perspective much better, because we've got really good evidence to show that untreated or poorly treated maternal mental health has long-term impacts on children as they grow up. And then of course you've got to assess about, well, what can we do with medication that's going to help to manage or deal with or improve the risk of postnatal depression. So those kind of things balance in, but perhaps are more on the positive aspect of trying to understand why you're doing what you do. Next slide, please. So here's an example of the situation. Oh, sorry, I haven't positioned that graphic at the top very well, but SSRIs, for example, you know, what are the things, the common medication? I suspect professionally you're coming across it all the time. You know, what are the issues? Spontaneous miscarriage, heart defects, you know, these sort of, my GP told me to stop taking it. I didn't want to harm my baby, so I stopped it. And then, oh my goodness me, these things can cause withdrawal at birth and persistent pulmonary hypertension. And, you know, blimey, as I said at the bottom, that's really serious. What's the risk of that? You know, and mothers who, you know, don't want their baby to, in inverted commas, suffer, and these sort of emotive words that come into that language, but are really understandable. So I think, I'm sure many of you would identify with that. Next slide, please. So, you know, how can we try to manage that process and all of those issues? And there's just some of the few things that I would suggest. You know, where's that information based on? What did you think? What is it you're worried about? Why are they worried, or why are you worried? And then when we do look at risk, I mean, just in my own field, for example, in neonatology, the risk of PPHM with this group of medication is vanishingly small. I've never seen it in 20 years of experience, and we work in a perinatal centre and we take babies with PPHN from around Sussex. I've never seen it. So, you know, yes, I'm not saying it's not there in the literature, but this is hen's teeth, and, you know, shouldn't be affecting in a major way. I've had a bit of an issue with the Talkspace people at the up in Newcastle who look at the I've gone blank now, their names, but who deal with these assessments of medications in pregnancy. And, you know, they're saying, well, you can say that because that's your experience, but actually we have to go on the published information. So I think this is one good example where publication bias affects what people perceive to be risks, even from the professional perspective. Next slide, please. Does anybody recognize that guy? This is not a very interactive session, I'm afraid, so I'm not going to hear much back from you, but he died last year, I think, but that's Donald Rumsfeld. Next slide, please. And much as I don't agree with most of what Donald Rumsfeld said, he did say this, which I think can kind of sometimes help inform this type of approach about the known knowns, the known unknowns, and the unknown unknowns, the ones we don't know that we don't know. And I think that's a kind of useful paradigm, perhaps, to look at medication in pregnancy. Next slide, please. So don't forget to add the benefits, as I explained earlier. But I think in this type of situation, the SSRI example, what are the known knowns? Well, malformation, heart disease, miscarriage, we can quantify those things. We can give people the risks and how much is that, you know, if 1,000 women took it, what would be, and it's giving that information in ways that people understand. I haven't got time to discuss today, but there are ways that you can phrase that information that very much colour how it's taken and how it's perceived. The use of the word withdrawal, I think it's really the wrong word, and perinatal adaptation is what I think is a much better way of talking about this kind of adjustment that we see in babies after delivery. And I often say to mums, you know, what happens if you miss it taking this medication for a few days? And they go, well, I just feel a bit weird for you know, they go, well, you know, did you come to any harm? No. Okay, your mental health might deteriorate, but actually that's kind of what the babies are experiencing. It's different. And of course, they're being exposed to the medication, but they're not got an underlying mental health problem. So, but they're still noticing that difference, much as if you stop smoking and you're kind of getting withdrawal overnight, but you don't come to any harm. I'm not going to go on any further about that. So we'll just move on to the next slide because I'm conscious of time. And here's an example, you know, can I breastfeed? And here's a mother with really complex medication, list on there on the right hand side, and a number of different diagnoses. She was in a wheelchair, and actually she has this mother with a lot of fiddling around what matters, what can we change, what can we do, what can we mitigate against some of the risks by measuring or doing blood tests or checking ECGs, for example. And that mum breastfed 3 babies now over the years, successfully, mostly for, I think, greater than a year. Next slide, please. It can be done. Next example, this mum, she had a biliary stricture, was up at King's, awful time post-operatively, it all went wrong, but ended up with cholestasis, liver dysfunction. She had a pulmonary embolism, but she was ended up on long-term morphine and codeine combined. So this mum was told several times by different professionals, you can't breastfeed. But actually, so what did? We changed her to a long-acting morphine with stable blood levels, and we stopped having the short-acting and various different things, which I can't go into detail now, but she breastfed. She came back to me when this child was 14 months old and said, okay, I want to stop now. What's the best way to do this? So it can be achieved. Next slide, please. And another kind of example, a mum with endometriosis, long-term infertility, malrotation, difficult abdominal problems, fentanyl patches, Clexane, aspirin. You know, how are we going to deal with some of those issues? And okay, if she needs opiates, can we manage the withdrawal? Okay, so your baby is well and can be treated and dealt with normally. And the answer to that is yes. Next slide, please. So what can we do? Well, I think we can provide context. I think we can help sifting information and the value of different evidence sources. We can provide reflection. What's important to you? What are the reasons of you thinking that or feeling that or whatever, and making sense of some of that, and then helping to summarize and come up with some kind of forward-looking plan. So I think that's an example of kind of how one might approach medication really in pregnancy. So finally, just to wrap up, I'm going to just a couple of slides about moving forwards. Next slide, please. Working together is crucial. There've been a couple of reports from Embrace just over a year ago now, which have really emphasized the biases of those with complex and multiple health needs with additional problems in the background, both in terms of race, but also social deprivation that add to both the experience, but also the morbidity and mortality. I'm not going to talk about that in detail because I think Andrew Cairns is probably going to perhaps discuss that in a little bit more detail, maybe. I'd also draw your attention to the Commission on Alcohol Harm report, which was published just over a year ago now, and how parental alcohol use impacts on the individual in terms of babies, long-term disability in terms of fetal alcohol spectrum disorders, and on relationships and families. Again, I haven't got time to talk about that in detail, but I'm just going to post those references for those reports in the chat for you to look up. And then finally, next slide, please. The National Childbirth Mortality Database report again came out last May, also just picks up the same themes really about poor maternal health during pregnancy, modifiable factors in terms of financial difficulties, debt, homelessness, parental mental health problems, overcrowding, unsuitable housing, and so on. So finally, last slide, and I'll finish. Looking forwards, I just raised two issues that have kind of come out that I've observed really over this time in terms of the perinatal mental health services. I think sometimes it feels that it's quite tightly commissioned, and maybe that's about capacity as well. But sometimes that makes the working together issues more tricky and more difficult. And I would encourage somehow if we can develop ways of that helping and improving, I think that would really, particularly in the context of these recent reports, help things move forward. And you learn so much from each other. And finally, I would also raise the issue of safeguarding when, sadly, babies need to be removed at birth from their mothers. And I have observed lots of situations where these mums, particularly with subsequent pregnancies, just spiral downhill. And of course, I've come across situations where, of course, they cannot continue to be looked after by the perinatal mental health service as dislocation of care because they are not with a baby. And that I would highlight again as just a problem I've observed. I'm not sure what the solution is, and maybe that's for others to suggest or sort out. So with that, I will draw to a close, and happy to take any questions if there's time for that.
Thank you so much, Neil. Gosh, so much to think about within your talk, and lots of things that I think are sort of dear to our hearts, and hopefully we are making progress on some of this. It does segue beautifully into Andrew's talk, so that's brilliant, because obviously Andrew can pick up on some of the issues in a bit more detail. I think we could possibly just have 1 or 2 questions if anybody's wants to pop their hand up. If not, I don't know if you're able to stay any longer, Neil, just to take a couple if they come up in the chat box.
Yep, I need to go in about maybe 15 or 20 minutes because I have another webinar I'm doing a bit later on this morning.
Okay. So be quick if you've got questions for Neil. I know you're probably chewing it over.
But even if people want to email you back, I'm happy to take, if you want to get
Lovely.
back to me after the meeting's finished, that would be fine.
Thank you very much indeed. And yeah, people saying that they've got a lot to think about now from your presentation, so that's always good. So just conscious of time then, and thank you again, Neil, so much. I will carry on and introduce Andrew, if we can go on to Andrew's slides. Thank you. So this is Dr. Andrew Cairns, who, picking up beautifully from where Neil finished, is going to talk about the mental health and adversity chapter from the Embrace report, which he was one of the co-authors. So delighted to introduce you, Andrew, and thank you for doing this for us. We've heard some bits of the mental health bit of the Embrace report, but it never hurts to go over it again. So I'm really pleased that we're going to have a bit of a reprise session on that as well. So over to you then, Andrew. Thank you very much.
Thanks, Jenny. Hi, everybody. I'm sorry, I've just joined in. I seem to have missed really what probably was a great presentation from Neil there, so I'm sorry I missed that. But certainly that last slide does beautifully lead into the discussion that I'm going to try and do in the next 15 minutes. I'll also give an apology first off, which is to say I'm really not very well today. So if I don't look very good, a bit sneezy, then I apologise for that. But I didn't want to sort of not provide this session for you. I've been asked to give an overview of the Maternal Deaths Inquiry report from last November in 15 minutes, which is quite an achievement. So I'm going to just really go through, but there's quite a number of slides in the pack that you'll have got a copy of, just that really gives you an oversight of the key bits, but we'll probably spin through them fairly rapidly. So Jenny said, my name's Andrew Cairns. I'm a consultant perinatal psychiatrist. I work up in the northeast, so I run a mother and baby unit in Morpeth in Northumberland and a specialist perinatal team across Northumberland, Tyne and Wear. I think when we think about some of the messages or the newer messages from the Maternal Deaths Inquiry, they really follow on very beautifully from that slide of Neil's. I think there's a huge question for us about how we deal with women who've had their babies removed, who've lost their babies through other means, stillbirth, neonatal death, and also those women who have really complex problems, difficulties with substance misuse as well, and how we as a system really meet their needs and try and have better outcomes. Hopefully most people will be aware of the Maternal Deaths Inquiry, but just to give you a very brief background to it. So the Maternal Deaths Inquiry has been around for a number of decades now, and there's been specific focus on mental health causes of death, certainly for a good 2 decades or so. And sadly, a number of the points of learning from those deaths have been very similar. So you'll be aware of issues of women having very rapid onset of severe illness, particularly puerperal psychosis, leading to a pattern of often violent suicides, and a clear opportunity to intervene with specialist services, mother and baby unit admissions. What we have seen in more recent years, though, is a shift in some of the population that are coming through, and that may be for a number of reasons. So as the the organisation that runs the maternal deaths inquiry has changed. The ways of ascertaining the cases has changed as well. So now the inquiry is run by Oxford University. They get reports of deaths from a whole host of situations. So they get reports from practitioners, often in maternity or health visiting, but they also go through coroner's records, and they've now got a linkage between birth data sets nationally and deaths, so that they can figure out and get a comprehensive group of all of the women that die. And the way that the survey works is that it gathers records from all health agencies involved, obviously maternity, obstetrics, GP, health visiting, mental health. One of the messages from previous years has been that mental health trusts are sometimes a bit reluctant to share their notes. So if sadly you're ever involved in a death, then it's really important that the notes do get shared with the maternal deaths inquiry. All of the records are completely anonymised, and then they're reviewed by assessors such as myself from a variety of professional backgrounds to see what lessons can be learned. So if we move on to the next slide, please. And the next one after that, yeah. The rate of maternal death, broadly speaking, hasn't really changed at all for quite a number of years. So we don't worry too much about the tiny text on this slide. The most important bit is the pie chart. And if you look at that pie chart, there's two segments down in the bottom right. So the sort of pinky, peachy sort of colour, that relates to the women who died through suicide. And the pale green segment at the bottom relates to those women who died through drug and alcohol misuse. And so in those cases, we're not talking about deliberate substance misuse overdoses that lead to death. We're talking about accidental overdoses. And certainly for many years, it's been recognised that there's often a pattern of reduction of drug use during pregnancy following the birth of the baby. That pattern can revert to previous high levels of drug use, but women may have lost their tolerance, particularly to opiates, and then accidentally overdose. This can be further complicated, as Neil was alluding to, really, where babies get removed by social services, and a lot of the sort of factors that may encourage women and their partners to try and limit substance misuse may be taken away. And as you can see, those two segments are really a huge proportion. Now, this pie chart relates to the women who've died after 6 weeks postpartum, so that what we call the late maternal deaths, between 6 weeks postpartum and 1 year postpartum. And you can see it's almost getting on for about a third of all maternal deaths in that period. But even if you look at the deaths throughout the entirety of pregnancy in the postpartum period, it's still the second biggest chunk of all of the deaths. So this is a really important area, and sadly one that we're not really seeing a reduction in rates. Next slide, please. Just very quickly to talk about mode of death. This has really not changed particularly. We've known for a lot of years that women who die through suicide in the perinatal period typically die through violent means. This is not something that's really changing over the years, and it is definitely different if we look at women across the whole age range. Their rate of violent suicide is not as large as at this point in life. Next slide, please. Now, there are a couple of differences. One is thinking about the timing of deaths. So this bar chart shows us the timing of deaths for those women who die through suicide. As you can see, there are some women that die through suicide antenatally, but the majority are dying in the first postpartum year. And that risk really doesn't change really throughout that first postpartum year. Now, if we were to go back maybe 10, 15 years or so, the maternal deaths inquiry used to show a drop off towards the end of the first postpartum year. Excuse me. And so this, to some extent, was one of the reasons why we thought about perinatal services stopping their involvement towards the end of that year, because it was felt that the risk of suicide was reducing. But as the ascertainment of deaths has improved, actually we're seeing that that rate doesn't drop off. So we don't quite know when the risk reverts to the normal baseline level. The other thing is to look at the two-tone colours of the bars. So the solid bit of the bar relates to women who don't have a history of perinatal loss, whereas the hatched bit is those women who've had a loss through any means. So it could be miscarriage, termination, it could be child removal by social services or the courts. But you can see that loss events relate to quite a significant proportion of the suicides, which is also apparent in the next slide, please, which is those women who've died through substance misuse. And again, you can see the hatched portion of those bars are quite significant. The pattern, though, of substance misuse related death is a little bit different. So we tend to see a peak in the middle of the postpartum year. So the early months after birth, there are a number of deaths, but it tends to be more sort of 6 to 9 months, sorry, 3 to 9 months that we see the majority of the postpartum deaths. So there is that difference, and it really shows the importance of ongoing support from, for example, addiction services postpartum. And I suppose one of my just personal reflections is that often we're very good at working with women who've got substance misuse problems in pregnancy. Certainly in our region, we have a lot of linkage, monthly meetings between addiction services, midwifery, social care to really manage the care, but actually postpartum, that support is much less evident. Next slide, please. Just briefly to touch on the pattern we saw in the last 3 years of highest level of care. So this is the highest level of mental health input that the woman experienced during her perinatal period. So not necessarily at the point she actually died. What we're beginning to see is more women who've been involved with mother and baby units and perinatal teams who are dying. And of course, that's not immediately surprising because we've now got much better access to perinatal services across the UK, much more equitable access to inpatient care. But there are a number of lessons from those cases which are in the report. And most particularly for me, a number of cases that I looked at around mother and baby unit deaths, where really I think we need to be clear that women who are admitted with severe illness, particularly psychosis, were looking for really full remission of symptoms before discharge, unless there's a good reason not to expect that. So somebody who's had chronic psychotic symptoms in the past, for example. But generally, women who have postpartum psychosis respond really well to treatment in the postpartum period. Next slide, please. So the key learning points from the report, just to summarize there on one slide: communication. Communication is always an issue, isn't it, in terms of sharing information? And we've seen for a number of years now cases where there was information in records, particularly GP records, of a past history. I myself recently have had a lady on the mother and baby unit who had previous history of psychosis and hospital admission, which wasn't passed on to midwifery, and so hadn't been referred into the perinatal team antenatally. We know from 2 reports ago that the pattern of red flags that are recommended to be observed for. So the red flags are reports of thoughts of violent self-harm, feelings of incompetency as a mother or estrangement from the infant. And the third one is rapid deterioration in mental state. We've also talked about amber flags in the previous 2018 report, about those women who've got a prior history of certainly perinatal illness, and the importance of risk assessment and management. So what we tend to see is fairly either naive assessments of risks, even when women or family members are reporting clear evidence of ongoing risk, acts of self-harm, repeated expressions of self-harm, but no active management. And I think this is one of the key things. It's not always about saying that any expression of risk should be managed by, for example, inpatient care, but there needs to be some sort of plan to mitigate those risks. And often there is literally no plan. So patients are seen by access services such as crisis or liaison, and they say no ongoing role for services. Issues about perinatal mental health services, which I'll come back to in a second, loss, which I mentioned there in the graphs, and engagement with relatives, which also will come to a slide in a second. Next slide, please. So just to really quickly illustrate one of the red flags. So a woman who died in her 30s died violently 2 months after the birth of her first baby. No prior psychiatric history, but developed what appeared to be a rapid onset anxiety and depressive symptoms weeks after birth. She became very preoccupied with concerns about the baby's health and belief that she was an inadequate mother, and there was evidence of self-harm. She was offered admission to a mother and baby unit, but this was declined, and she was managed by the home treatment team. So very sort of characteristic example of a woman who had both deterioration, the self-harm, and also this sense of estrangement. And in some of these cases, when you read the records, you get a strong sense that actually this verges into a psychotic belief that they're not capable of caring. And it's important to think about what the underlying factors may be, because you do come across, sadly, a number of women who've had very poor experiences of being parented, who quite genuinely have concerns about their capacity to parent based on their own experiences. But in these particular cases, that isn't evident. Next slide, please. And I mentioned just before there about this issue about active management of risk. Risk assessment is not a foolproof science, is it? But we need to be clear about how we're managing risk and what the plans are around this. And it's not sufficient simply to say that there's no ongoing need for any sort of input. Next slide, please. We mentioned about loss. So this case summary is an example of that. So a woman in her 20s who died violently a few weeks after a termination of pregnancy, had a prior history of self-injury, but this hadn't been known at the point of booking. She'd presented to see her GP with low mood and suicidal thoughts, and over the subsequent months expressed further thoughts that she didn't want to be alive, developed quite specific thoughts about self-harm and suicide, thoughts about drowning, overdose, hanging. And then she went on to have 3 contacts, one with psychological therapies, a GP, and then a liaison team, and described recent self-harm on both occasions and an inability to keep herself safe. None of these encounters resulted in any plan for immediate safety. And reading this vignette, we may have thoughts about what the underlying reasons for this presentation may be and what sort of diagnosis we're thinking about, and thus how we might approach management of risk and self-harm. But I think the key thing is that in these cases, and in this case that's illustrated, there was literally no plan. So it wasn't that people were taking a positive risk approach to this case. There literally was no plan as to how they were managing it whatsoever. Next slide, please. So essentially a fairly obvious learning point that there needs to be an overarching consideration of past history and pattern of symptom development when assessing risk. Next slide, please. I think given the time, what we'll do is jump on, and as I say, you can go back and have a look at these slides. So next slide, please. So if we think specifically about perinatal mental health services, and this is something that's becoming more evident now because we're getting more cases that have been involved, there's a fairly obvious problem which is around lack of referral, and I've described a case in my own experience recently where that hadn't happened because information had not been adequately shared. There are problems with restrictive referral criteria, and I think this is what leads on quite neatly from Neil's presentation at the end there, that we're seeing cases of women being excluded on the basis of diagnosis. So specifically those women who've got diagnoses of personality disorder. And of course, this is a difficult area because often women who may have been given a label of personality disorder or complex PTSD or similar sorts of labels will have had really quite traumatic experiences in their own early life and may well have had quite poor experiences of being parented, which then places them at risk of struggling to adjust to becoming a parent themselves. And you'll read things like, for example, people saying, well, this woman is stable at the current time, but with no real sort of thought as to how things might be after the birth. And perinatal services generally are really good at thinking proactively about how things will be after the birth, specifically for women with diagnosis of bipolar disorder or psychosis. We're very used to the idea of anticipating the risk of relapse, and I think the challenge here is to really try and do a similar sort of thing for those women who have a history of significant trauma and adversity. Problems about response times and lack of clarity about specialist pathways into care. So in different areas, services are developing in different ways. We've obviously got the specialist maternal mental health services, not terribly helpfully well named, running health psychology in maternity settings. We've got specialist midwives in certain areas and not in other areas. And when you're going through the anonymised notes to try and understand what's going on, often what you figure out is that the woman may have been referred, say, to a specialist midwife and not a specialist mental health team. But people don't necessarily understand or appreciate what those roles might or might not offer. Next slide, please. I think we'll jump on because we're short of time. What was the next slide again? So as I've mentioned, there's this pattern of issue about diagnosis, refusal of assessment, particularly where there's been issues with thoughts of violent self-harm, and referrals restricted to particular groups, so women who are perceived to be at high risk. Next slide, please. So the learning point here really is about how we commission services and how we provide services. And I think this is a huge challenge because I don't think there are any specialist perinatal teams there who have lots of spare capacity and lots of time to be taking on additional patients. So we need to think carefully about this. But we need to make sure that specialist services have the capacity to assess and manage all women who require a secondary mental health input. So that's those who are under CTTs, EIP, etc. And that they're resourced to be able to do that. And that we don't exclude on the basis of diagnosis. Next slide, please. And the point there about pathways. We'll move on to the next slide, please. Mentioned a bit about loss at the beginning. As you would expect, the types of loss between these two groups of death, suicide and substance misuse, do vary, with the women who die through substance misuse have a greater preponderance of children being taken into care through local authority proceedings. Next slide. Issues about engagement with relatives. Now, some of this is not new, and we recognise that in the past, certainly around women who've got psychotic illnesses, partners and carers are being given responsibilities that really are beyond their capacity to manage. So caring for very poorly women, often with significant risk of suicide, and for a newborn baby at the same time. And so really the learning point remains that we need to be very cautious and careful about the responsibility that we're giving partners and carers. Next slide, please. Prescribing. One of the things that we've recognised in a number of cases in the most recent report is that decisions are being made to discontinue medication early in pregnancy, perhaps appropriately after some consideration with the patient of what their wishes are. But there's then no review of that in the postnatal period when there's an increased risk of relapse of perhaps depressive or anxiety symptoms. And so it's really important that we're aware that medication are both not being inappropriately discontinued because of some perceived risk of medication, which may not necessarily stand up on evidence, but also that where it is discontinued, that there's then a review of that decision to make sure there's no recurrence of symptoms. Next slide, please. And so that's the learning point that goes with that. Next slide, please. Just really reinforcing the message, and this is something that in my own day-to-day practice I still often have discussions with GPs about, where you've got somebody who's responded well to a treatment in the past. We need to be expecting that they're going to have a similar response. So this, sorry, I'm getting myself muddled up. This learning point relates to certainly to a number of cases where the women died in mother and baby units. There were at least two that I looked at where they were not adequately treated with medication prior to discharge, even though there'd been a good response on a previous postnatal episode where they had been treated at higher doses with the same medication and showed a full recovery and then remained well in the interperiod between the two pregnancies. So it's really just reinforcing that message that we expect these women, generally speaking, to do well. Next slide. So just a brief couple of slides thinking about substance misuse. What we saw quite a bit of within these reviews was combinations of different drugs, so polysubstance misuse, often opiates, benzodiazepines. There were quite a few using pregabalin, gabapentin. Some of those, interestingly, were prescribed, and there were patterns of increasing use through pregnancy that professionals were aware of. I certainly looked at a couple where GPs were documenting that they were concerned about escalating use, but then seemingly unable to curtail it or manage prescriptions in a way that prevented that from going on. Next slide. And the pattern here, and this is a pattern that we've seen certainly over the last 3, maybe 6 years of the maternal deaths inquiries, increasing numbers of cases where these women have a history of multiple adversity. So we're talking about childhood adverse experiences, childhood abuse, adult abuse, often social services involvement and child removal. And in quite a lot of the cases now, what we're beginning to see is a pattern of this history of multiple adversity then leading to one of 3 outcomes: death through suicide, death through substance misuse, or death through, sadly, homicide as well. And again, issues about communication and sharing of information. Next slide, please. So where women have substance misuse, we need to recognise that they're much more vulnerable and at greater risk of relapse in the postpartum period, even when they've apparently shown improvement during pregnancy, and that's for the reasons that I talked about earlier on. And so we need to ensure that this is reviewed and that opportunities are taken for re-engagement in the postpartum period. Next slide. Domestic abuse. This is poorly reported and recorded in the notes, but certainly we know that a significant number of the women who died were victims of domestic abuse, but a significant proportion of the records just didn't have this information recorded at all. Next slide, please. And just to finish, think about the women who died through homicide. So 11 women in the last 3-year period up to 2020 were murdered during pregnancy or up to 1 year postpartum. As you would expect, a significant number of these were victims of domestic abuse, but again, further information was missing in a number of records, so that may have been higher rate than that. And often information was not being shared, so cases where police had concerns about partners but weren't sharing that information with health, for example, was a problem in certainly one case we looked at. Next slide, please. And we'll just jump past that vignette because I'm conscious of time. So just really to sort of make this point about complex adversity, that we see this in all 3 groups. And I think the challenge for us as perinatal services, if we go back 20 years or so, the focus was on about managing women with severe mental illness, specifically bipolar disorder, psychosis, severe depression, who'd required hospital admission and were at high risk of relapse in a fairly defined window in the early postpartum period, who would respond well to medication, whose risk could be managed through inpatient care. And what we're seeing now is a shift towards this much more complex group. Certainly in our clinical community service, it's a very large proportion of the women that we're working with, but it's much more difficult to make changes. It's not simply about medical treatment. It's often needing a multi-agency approach. We need to address symptoms of illness they may have, depression and anxiety. We need to address underlying problems with personality traits or trauma through psychological interventions if they're in a position to engage with it. Often we need to be working with addiction services. There'll be children's services involved. And admission, unfortunately, doesn't offer us an easy way out of this, because at the very best, where it's considered, it's often going to be offering respite. So they're a much more difficult group to work with to bring about positive change. And I think numerically, they're also a much bigger group than dealing with postpartum psychosis. So this really is our challenge going forward, is how we commission services and also develop services working together across not just health, but also social care to manage and try and bring about better outcomes, both for the women and for their families, and preventing the ongoing intergenerational issues that we are all very familiar with. Next slide. And we'll jump past that vignette as well. As I say, they're all there in the pack for you to have a read of later. And I think we'll finish there. Do you want to jump on? That's probably the last slide. Yeah, classification account. So I've whizzed through that, slightly run over, so apologies, Jenny. I don't know if we've got time for questions.
You're an absolute super. Thank you so much. Yeah, I think you can see there's lots of applause there for you, Andrew. I don't think we're going to have time for questions, but some really strong messages from both you and Neil about us working together, not silo working, making sure the woman's in the middle of everything. So that's something that we'll take forward. So I won't go massively over time, but here we are, the next one, April, focusing on research in practice. Yeah, lots of things to take away from today, but Andrew, thank you so much, particularly as you're poorly. I think you get extra brownie point for coming and presenting when you're not 100%. So thank you. Okay, everyone, I think we will have to go promptly now because we're all jumping onto something else. So thank you all for coming, and I hope that was helpful and interesting and thought-provoking, of course. So hopefully see you on the next one.